Okay, well, thank you very much for inviting me to speak today. I was asked to speak on some issues related to healthcare financing and the sustainability of the healthcare system. And of course, I'm going to try to tie in some things related to equity and the major theme for today's talk and session. So I want to start in actually echoing some themes from the first talk today, which is we talk a lot about sustainability. What are we trying to sustain? What is it that we're so concerned about losing? And the rhetoric in the discussion often sounds like the current system, where we have to sustain the current system. But of course, having listened to speakers so far today, we know we actually don't want to sustain the current system. We want to reform the current system and improve it in many, many ways. So I think it's important to be clear. I think what we mean is we want to maintain certain principles that we associate with the system. And I think we're going to face some very important challenges around, do we want to just sustain access to care or equal access to care? Right? Because those are two very different principles by which we might want to operate the system. We, of course, historically have espoused the idea that we want equal access to medically necessary services as long as they're from a physician or done in a hospital. And some of the kinds of reforms we often entertain, particularly in financing, might still argue we're going to ensure people have access, but we no longer say that it has to be equal access. Some could have more access than others. Okay? So I think we need to be clear about what we're trying to sustain. Secondly, we want to talk about what we mean by sustainable. And again, echoing some of the themes from this morning, most of the attention gets put on economic sustainability. But in fact, there's a number of dimensions to sustainability that I think we want to talk about, we want to analyze, and consider when we think about the sustainability of our healthcare system. So in addition to economic, I will just, for instance, label the political sustainability, the social sustainability, and the legal sustainability. And I'll say a bit more about most of these, but you can obviously understand the principles of most. Political meaning amongst our political system and the leadership we have and through politicians. Social meaning the support within broader society for the system as it's operating. And then legal meaning it's not just the U.S. system that has legal challenges in front of it. There's a number of legal challenges to the Canadian healthcare system, the principles of the Canadian healthcare system. So although we're focused on the U.S. and their Supreme Court, particularly these days, there are a number of important legal challenges to the way we regulate our healthcare system in Canada. A couple of things about economic sustainability. We usually think about it in a couple of different ways. The most common is probably, is the amount of our healthcare spending as a proportion of the income available in society sustainable? And so we usually look at something like this. This is how much does our healthcare spending constitute of all the income available in society? And you might not be able to read all of this, but the U.S., of course, spends the highest percentage of its income, a little over about 17.5%. These figures are from 2011. Netherlands and Canada's in the second group, all quite similar, between kind of 11 and 12% of our whole economy is devoted to healthcare services. And of course, that's been rising over time for a number of reasons. The latest blip in the last number of years has been mostly the fact that our economy hasn't been performing very well. Well, healthcare spending continues on, so it's been more the denominator that has not been growing as fast as the expenditures themselves. But nonetheless, this is a common indicator of sustainability, and at least by this measure, of course, Canada is well, they're in company of many other countries. There's a good company we can debate, because that ratio has been increasing over time. This looks at public health care spending. The first graph was all healthcare spending. This is just the public spending. And here, Canada is even kind of lower down the rung because relative to many other countries, our publicly financed system is smaller than the UK, Sweden, Denmark, many, many other countries of what we would see as our peers. So naturally, our proportion. What many people would not appreciate is, in fact, our public spending as a share of our economy is smaller than the U.S. public spending. The U.S. spends more of their economy through their public healthcare system than we do. Okay? That's because they spend a lot. We don't spend as much overall. Public sector sustainability is often thought about in terms of how much is healthcare spending taken up of our program spending of all the government. This, of course, is a huge issue as a result of budget speeches such as we had yesterday, or as a proportion of tax revenue. This graph is typical of the kind of thing you see. We have a pointer here. So This is healthcare over time, of course, eating up an increasing proportion of program spending in Ontario. We see other services, children's and social services decreasing. We see a bit up and then down for, this line is other, this is children and social services. The point is healthcare is becoming a larger and larger proportion of all government program spending, and the question is it sustainable? Is it just going to crowd out all of the other kinds of services, many of these and some of the kinds of determinants of health that we've already heard about today? And in fact, the plan put forth yesterday in the budget speech is for this to continue, in fact, probably to increase, because many sectors, one of the areas of the government spending in Ontario are going to either shrink or stay constant, while healthcare, they're going to aim for increasing to only 2.1% a year over the next 6 or 7 years. So this trend is going to continue. I would caution, this is not necessarily a bad thing, right? This is what's happening as our income grows, as we grow older. It's natural that more of our income would be spent on healthcare, right? This is a natural thing to happen. What we worry about is the degrees to which it's happening and the extent to which it may be crowding out other really valuable things that we could be doing through our government and our public sector. So this is the kind of concern that's behind the sustainability debate in Canada. Can we maintain and sustain our healthcare system given that it's eating an increasing proportion of government services and perhaps even the economy overall? When I think about challenges to sustainability and then the sequelae, what are some equity implications, in fact, if in some sense it's not sustainable? Because, of course, the system is designed to try and achieve equitable outcomes, certainly at least equitable access to services. And what would be the consequences if, in some sense, the system weren't able to continue as we, at least according to the principles that we've articulated historically? Well, in terms of the political sustainability, I'd flag two things. The first one being, we currently have a federal government that has little interest in a national system with national principles, right? I mean, this has become very clear that their view of the fiscal federalism is there's provincial areas and there's federal areas, and I'm not interested, if you're Stephen Harper, in getting involved in provincial stuff. And they made very clear with the accord, I mean, there was no negotiation. They just came out and said, oh, this is what's going to happen. We're going to give you the 6% for X number of years, then it's going to go to an escalator linked to GDP growth and so forth. There was no discussion or debate. They brought in, I should be clear here, this was not the Harper government. This was negotiated previously, the move towards equal per capita funding, which will reward Alberta and hurt fiscally a number of the other provinces. Again, to be fair, that was not a Harper initiative that was signed in 2007. The point is, we have a federal government right now that has little interest in the national standards. A second aspect, can we have the required political discussions about public and private roles that we really need to have in Canada? It's a very emotional debate. It very quickly turns into not an entirely thoughtful discussion on both, in some sense, sides of the issues. But we need to be able to do a better job of that. I would add here a third point that I didn't put up there, but again, leading to the fiscal federal, we don't have especially good fiscal federal relationships going on right now. And in fact, this is crucial to maintaining our system well into the future. So I would argue there's a number of political phenomenon right now that, in some sense, put the system as we've known it and the principles we care about historically at risk as we move ahead. When it comes to legal, I mentioned there are legal challenges in Ontario, in Alberta, in British Columbia. Probably the most extensive one is out of British Columbia through Brian Day, who runs a series of private clinics there, also a former CMA president. And they're challenging not just the private insurance regulations that prohibit private insurance for publicly insured services. He's challenging also regulations of fees physicians can charge in the public sector, regulations about the choices doctors can make in terms of public and private care. So this suit is really going after the gamut of regulations that many would argue are responsible for how Canada has been able to inhibit the growth of a strong private sector, certainly in the physician sector anyways. And it's not at all clear how this suit will turn out. There's a very good chance that the decision will be in favor in striking down these regulations. right? I mean, it's a charter. This would have national implications. Many of you are probably familiar with the Quebec challenge, which was simply Quebec's private insurance law was simply found to contravene the Quebec charter. So therefore, it only had provincial implications. This will have national implications. Under the radar for most people, but really quite an important potential development that would wipe out a number of the kinds of regulatory approaches we've taken to insurance and regulation of providers in the system. So very important. When I come more towards back to some of the economic dimensions, nothing's more important than what happens to our economic growth over the next little while, right? If we could inch that up, a quarter of a percentage point higher, half a percentage point higher, it would solve our budget problems over time. So, unfortunately, this is something we don't control very much anyways. We're subject to a lot of international trends. We can be happy that the U.S. seems to be doing much better these days since they're one of our major trade partners. Nonetheless, I think it's really important to emphasize that even with tough budgets, no matter what's coming down the pike, a lot will hinge on what happens to our economy over the next number of years in terms of what kind of restraint has to be shown. When it comes to healthcare spending itself within the system and the challenges that poses towards sustainability and the maintenance of the kinds of principles at the heart of the equity within our healthcare system, this is a picture from a recent CIHI report, and this says that between this 10-year period, there was an average annual growth rate of healthcare spending, public healthcare spending of 7.4% during that 10-year period. This was made up as follows. 2.8%, which is general inflation in the economy. Nothing specific to health. 1% was just growth in the population. Again, nothing we particularly would worry about because the population is growing. Of course, you need to spend more. 0.8% or 0.8 is aging. 1 point here is out of 7.4%, it's the smallest factor. We talk about it the most, but in fact, aging itself is not a fundamental problem for the system. It poses challenges, but they're manageable in and of themselves. The biggest chunk that we can do anything about, and we should care about, is this, which is basically stuff we can't measure. We give it fancy names. Economists call it technological change. We sometimes some people call it enhancements and all sorts of nice labels that makes it seem good. In fact, it's just stuff we can't measure. And the problem with some of the labels is it makes it sound like it's something we can't control. If you say, oh, that's technological change, well, that's something that's happening out there and it impinges on us, there's nothing we can do. In fact, there's a huge amount of this is under our control of policy. And the kinds of policy decisions we make that are coming down in the next few years will determine the impact of A, can we control this as planned? Remember, McGinty's target, 2.1%, down from 7% during this period. Huge challenges. Second, how we do this is going to have huge implications to what happens to access to services. The couple points I want to emphasize. One is we can control that. We've shown it in the mid-1990s. Look at what happened. Oh, big positive technological change. Well, suddenly, what, did they stop inventing things? No, black means we had negative growth here in this component, this other category. And what do we all know what that was? We put in global budgets, we said we're not going to spend more, and we didn't spend more, right? It wasn't particularly pretty, and it's not clear that we accomplished a lot in terms of fundamental reform beyond fiscal restraint, particularly during the mid-1990s. But my point is, if we're determined, we can bring that number down. The question is going to be, what are the consequences of that? The second point I would make is, as hard as this was in the 1990s, I think it's going to be harder these days for a couple of reasons. One, I think the system's probably a bit leaner. I mean, we have fed the beast for the last 10 years, but still, it's probably leaner now than it was in the early 1990s. Second, the population, of course, is aging. It was then as well. The problem is we have a whole whack of people turning 65. And although you don't suddenly get a lot sicker when you're 65 than when you're 64 and a half, from the point of the public sector, that's important because suddenly you now are eligible for ODB. You're now eligible for a whole bunch of stuff that costs the public sector money that you didn't before. So that's going to put pressure on it. The other thing I would say that is going to put a lot of pressure is MD supply. The mid-1990s was a period when we had flat growth in physician supply per capita. This is a picture of what's been happening. This is medical school enrollment. This is medical school graduation. And we'll see, maybe there's some noises about changing this, but so far there's no sign that this line is going to start turning down at any time soon. So we're producing doctors at a rate much higher than the replacement rate. A couple of comments. One, you can argue that, in fact, this was necessary to make up for problems of access to physician services and so on and so forth. Second, the population is aging. Third, a higher proportion of these are women, and we know that women don't work as many hours and deliver as many services as male physicians. We also know, something we learned the hard way, is that male physicians, the biggest reason I think why we had problems of access to services starting in the 1990s is male physicians started working substantially less, 20% less in terms of direct hours of patient care in the late 80s and early 90s. That was the biggest reason why we have problems of access, not any changes in the numbers themselves. So some of this is making up. But again, we're doing this at a much higher rate than probably we need for replacement. The other reason why this worries me in terms of patterns and ways we can organize care is we now produce, of course, nurse practitioners. We produce physician assistants. We produce all sorts of people we're trying to integrate in the system. And unless we're willing to put up with unemployed doctors, this could really compromise our ability to achieve the kinds of delivery models that we think are necessary for providing the access to the full range of services that people need at the primary care level in particular. So I worry about this in terms of as things unfold over the coming years, in terms of both the ability to control spending, but I think more importantly, the impact it may have on the kinds of reforms we can consider to the organization delivery of the healthcare system. Two other points to kind of wrap up, and these are more speculative on my part, but I think there's some things in terms of the evolution of the healthcare sector that will impinge on our system of financing and our ability to maintain some of the kinds of principles that have been crucial to our system in terms of equal access to care. My concern is it's going to lead to perhaps a certain kind of undermining of the principles for reasons that in some sense don't violate any of the current regulations. The first one is we know that chronic disease is what's the name of the game these days, right? It's no longer just people, you have appendicitis, you go in the hospital, you have a surgery and come out. And so chronic disease, there's a lot of gray zone. At what point has your arthritis and your knee become such that you need to get it replaced? When it goes from just being an inconvenience that you don't treat to something that's a serious problem. My point is it's going to blur this idea of what's medically necessary, not medically necessary. Fine, we can probably handle that. I think it's going to lead to a certain kind of questioning of judgments. And in combination of a second factor that's going on simultaneously, we know that some of the fastest growing areas of medicine and technology are lifestyle stuff, right? We know we have a bunch of vain baby boomers who will pay lots of money to have things done that aren't medically necessary so that they can think they're still 40, right? What will this do? Well, first of all, once again, there'll be a certain cognitive dissonance. I can go to my doctor and get X done immediately. Why do I have to wait for Y? It's the same provider in some cases. What's going on here? Why? It makes no sense this should happen. Secondly, this investment in private non-medically necessary services, entirely appropriate within the system, entirely appropriate because they're outside, is going to attract the kind of financial capital that's going to be looking all over the place for other ways to make money off of this investment that we've just put in this clinic over here. And that's going to lead to a lot of pressure to open up the regulations and to be able to start using that capital for medically necessary services. So this is slow moving. This is just things I worry about at night. But I think over time it's going to lead in a particular direction that's going to make it harder to maintain the kind of social support amongst the population for some of the principles, because there'll be more things that challenge their understanding of how those principles play out. The last point, though, just a bit of summary then, therefore, I think there are clear challenges to sustaining the system based on the principles that currently underlie our Canadian system. And I really am focusing again on physician hospitals, because we know there's all sources of inequity once you get outside those sectors, in drugs and dental and so on and so forth. but even within the core system as we understand it, subject to the Canada Health Act. I would argue that actually financing is not where the action lays. The most important scope for reform is in the organization, funding, and delivery of the system, and in particular the culture that operates in the system. Because fundamentally, the system of finance is a perfectly rational, reasonable system. There are going to be challenges and constraints and so forth, but that's not the problem. If we can undertake this kind of reform, then we'll be able to finance the things that we think we really want to achieve through the system. Thank you.